Hi, sir.
Hello,
I'm
Likita.
Likita. Today, I wanted to have a conversation with you about government funded health insurance. So, the combined state of Andhra Pradesh in 2006 launched a program called Arogyasri. The program was a huge success initially, and it was eventually adopted by other states. Even the government of India came up with its own program called the Ayushman Bharat and extended coverage to all states. Why was this a huge success?
Likita, one of the biggest causes of impoverishment in India is the healthcare expenditure, particularly what we call the catastrophic illness. Day-to-day illness is one thing, but you require a major surgery, some other problem. Not only is your productivity down, you suffer the pain and depression and anxiety because of the disease, but economically you are shattered. First of all, you don't work during the period of illness, therefore, income comes down. If you're already on the margins of poverty, it drives you into poverty.
Yes.
Second, the costs of medical intervention, particularly hospital intervention, are so great in the country. Though by global standards it's not high, but relative to India's per capita income and the poverty of our people, the costs of hospital care are so great that families are devastated. The evidence shows that out of pocket expenditure is predominant in India for healthcare. About 55 to 60% of the money is spent out of pocket, not even insurance, not private expenditure, private out of pocket expenditure on the spot when you have a problem. As a result, about 25% of people hospitalized in India, they become poor. They were not poor before. A large number of people are forced to sell their assets or becoming indebted.
Right, sir.
So, in that context, what is Arogyasri? It's not improving the health or PM Ayushman Bharat. It is shifting the burden of payment of hospital costs from the individual pocket to the state.
Yes.
It's a huge relief for the poor people. Healthcare is not improved, the same care you're getting, not much difference. But the anxiety, the stress, and the impoverishment, the indebtedness, and selling of assets, that disappears. So naturally, it's very popular because healthcare, unlike education, the people see the benefits instantly. If you, as a doctor, treat me free of cost, I am free from disease, I see the benefit immediately. If a bill I would have paid 1 lakh rupees to the hospital, the government is picking it up, I see the benefit immediately. So politically, the returns are very great because when you vote next time, you are grateful and you vote for that party. So Dr. Rajasekhar Reddy started this in Andhra Pradesh. It quickly became very popular in the state and spread throughout the country and now became Ayushman Bharat because it's a case where the burden of payment is shifted to the government. And two, the results are instantaneous, the gratification instantaneous, therefore the people return the favor by voting. And the reason why it actually operated well, if it's a government program, government hospitals, given the lethargy of public services in India, it would have failed. But the heart of the issue is competition and choice. You can choose any one of the multiple providers, public sector or private sector. There is competition among the providers. The patient chooses where to go. Therefore, what you did is with public funding, you fused the market principle, and therefore it actually became an operational success. It was a political success. So I think there's something to it.
Sir, then despite this initial success across all fronts, then why is this scheme or this program riddled with so many problems? Across all states, there are complaints that private hospitals are turning away patients. They are applying for de-empanelment, and they're saying that funds are delayed or their claims are rejected outright.
In the first flush, the novelty of the scheme being what it is, a great enthusiasm. All the private hospitals, including corporate high-end hospitals, spending a crore or two per bed on capital investment, they also joined because after public money is coming to pay for the services rendered by the provider. So the overall kitty of payment is increasing. And governments also were somewhat naive. They allowed very high costs. They didn't have enough knowledge base. Economic use of resources was not at the top of their mind. And because it was early days, only a few people utilized it, relatively speaking. I'll give you one or two examples of what happened in Andhra Pradesh. They included a somewhat sophisticated intervention called cochlear implant, deafness by birth, costing in those days, 2006, 18 lakh rupees
Per surgery, sir?
per surgery. That means today, probably you can assume, some 20 years later, about 30, 40 lakhs covered under Arogyasri. One hospital in Hyderabad conducted 18 surgeries on one single day, made it a world record. Nowhere in the world does it happen in rich countries because that intervention that frequently is not necessary and is too expensive. So all these things happen. Over time, governments wake up naturally because there's always resource constraint. What is poverty? You don't have enough resources to meet your needs. And therefore, cost cutting. And then because government is a monopoly buyer of services, what we call monopsony, government could command the market price. So they drove down the prices, sometimes reasonably, sometimes unreasonably. It may not even work out well, actually, sometimes. So what happened, as the initial enthusiasm faded and the resources per intervention came down, either highly motivated providers, irrespective of whether they make a profit or not, or the low-end service providers whose costs are already cut down, and therefore they can still provide service at that cost, they remained. The high-end providers, the tertiary care hospitals, multi-specialties, the star hospitals, no, the big posh hospitals, they could not afford these costs. So they slowly disappeared from the scene. Also, initially, because of the political interest and enthusiasm, government actually provided resources. In most states, slowly, government was reimbursing very slowly. Hundreds of crores pending bills were there. Some states were doing well, notably, if I recall, Andhra Pradesh and Tamil Nadu, 4 or 5 years ago when we looked at the data, they were the best states in terms of actually allocating resources for this kind of a risk pooling model and then utilizing. Many other states, including Telangana, a breakaway state of the then Andhra Pradesh, were not spending that kind of money. So even payments were delayed because of budgetary constraints. That's where it is. But Mr. Narendra Modi, because he knew the importance of this program as Chief Minister of Gujarat, he embraced it at the national level. Now, slowly, a framework is being built.
So then, since this is such a high impact program, then why aren't governments motivated to rationalize the program practically and in an informed manner? And also, what are the disincentives to incentives to private hospitals to take up empanelment? What could be the incentives?
First of all, we are still in early stages. Therefore, the understanding of the costs and benefits and how to improve the system, I don't think at the national level attention is still being paid. We are still rolling out, so to speak. While the program is a few years old, maybe 6, 7 years old, even today the coverage is very limited. The fact that, for instance, Andhra Pradesh is allocating 2,700 crores for this Arogyasri program. Tamil Nadu probably a similar amount, roughly about per capita expenditure of 500 rupees based on population basis. The national government is allocating just 9,000 crores for the whole country. Now, if you take 500 rupees or 400 rupees per capita expenditure, the national government should allocate something like 40 to 50,000, or whoever the government for the whole country, 40 to 50,000 crores. We are nowhere near that. So it's early stages. That's why I say, though the program is a few years old in a large and complex country, it is still in the rollout stage. It will probably take another 4 or 5 years for it to be fully rolled out. And the budget should probably rise to at least 25, 30, 35,000 crores, given all the budgetary pressures, etc. We'll see how it happens. But as you said rightly, now is the time to actually look at the experience of states which already implemented for several more years, like Andhra Pradesh. Tamil Nadu is doing a pretty decent job. And then designing a better model which is cost effective and guarantees much better quality of health with the same expenditure. I'll give you a couple of examples. The data from Andhra Pradesh, Telangana, and Tamil Nadu, and I'm sure something similar is happening in other states too, where it's rolled out to full extent with state government's complete participation. About half of the expenditure under this is going towards sophisticated, high cost tertiary care interventions, particularly 4 or 5 of them. Cancers, with the lifespans increased, incidence of cancer is going up. 40, 50 years ago, cancer meant death sentence mostly. Whereas today, in 60, 70% cases, a significant improvement and survival rates are possible, but it's very costly. Whether it is medical therapy, chemotherapy, whether it's radiotherapy or surgery. A lot of money has to be spent. Heart disease, again, 50, 60 years ago, there's very little we did for heart disease. You controlled blood pressure, you controlled heart failure, you gave some vasodilators to expand the blood vessels supplying blood to the heart. Really not much more. Today, you have sophisticated interventions, whether stents, medicated stents, or open heart surgery, coronary artery bypass grafts, ABG as we call it, bypass surgery. So all kinds of sophisticated interventions are possible now. And they're helping. But the cost is very high. A third is kidney problems because of diabetes, because of other problems, overuse of certain medicines, whatever, kidney failure. And therefore, either kidney replacement or management of acute kidney disease or chronic kidney disease or dialysis and all kinds of things, taking away a big chunk of money, particularly because India is becoming increasingly known for diabetes incidence. In fact, some people are calling India the diabetic capital of the world. The fourth is trauma. India, remember, has the highest number of fatalities on roads and injuries on roads.
Yes.
And obviously, trauma, once an accident is there, multiple injuries, all kinds of things, it costs enormous money, and it's very important to quickly address that. These 4 or 5 areas are taking away 50% of the money. And they're all high-end tertiary care interventions, often requiring multi-specialty hospitals. In some cases, in end-of-life care, while the cost is high, we are anxious to save the patient, the benefit is not commensurate to the cost. So I believe there is a case to take them away from the Arogyasri pooled model of competition and choice. Develop high-end tertiary care units in government. Let's say, for instance, out of all the government teaching hospitals, about 140 or so are the old teaching hospitals with 1,000 beds and a tradition of multi-specialty care. We can improve the facilities significantly, but at a relatively less cost compared to the high-end corporate hospitals, and enhance the credibility by bringing in high-quality expertise from private sector on a consultancy basis, and have a system of queuing so that the temptation is not to have heroic interventions to enhance the billing, but actually do what is necessary for the patient in a cost-effective manner.
Right.
This is one of the challenges in medical care. If I am a patient, even if the chances of improvement are very marginal, I would think that my life is so valuable to me that if $1 million is spent, if 1 crore rupees is spent, I'm quite willing. That's naturalized, right? Human beings
Yes, sir.
treasure life. But for a society at large, with that 1 crore rupees, maybe 100 people could be saved. And therefore, a much more selective intervention, instead of subjecting the patient at the end of life to harrowing interventions, very sophisticated interventions, for which there is no serious evidence of improvement of either longevity or quality of life. That will work when somebody is making a judicious choice. That's
So-
what happens even in NHS in Britain.
Yes.
See, there's a queue system. You simply can't get whatever you want because this is what is available, and they must decide what is the best possible optimal care depending on the patient and resources available. Otherwise, healthcare costs world over are a bottomless pit. Initially, we start off with something, but costs go up and up and up and up. Britain spends 10% of GDP on healthcare, all from the tax money. People are dissatisfied, doctors are dissatisfied, nurses are dissatisfied. On any given day, some doctors, some nurses on strike, the patients are unhappy.
Yes.
And the budget is unhappy, the treasury is unhappy. So we have to really improve the models, device models, and make sure that cost effectiveness is there while quality care is available to everybody. You have to make sure that it's cost effective, affordable, and incentives are there for the patient to preserve health. Like, for instance, Singapore has designed a very sophisticated model. They have 3 funds. Medisave, which is universal. You save money through your provident fund or something, and you can use that money for availing the care under subsidized rates with some co-payments. Then MediShield is available, and that is for hospitalization and other interventions. It's like an insurance program, but you pay.
Yes.
Maybe government again will subsidize.
Yes.
Then if you are an indigent patient and you really need certain remedies and they cost a great deal of money, then there is a gratis fund, a Medifund where government simply gives you a grant, like your Arogyasri or something else. But in all this, there's an incentive for the patient to preserve her health.
Yes.
Exercise, proper dieting, control of body weight, and so otherwise the cost goes beyond the point you have to bear out of pocket. But if it's really genuinely necessary, then certainly there's also a protective shield available in the form of Medifund. So we require sophisticated models because ultimately cost, care, quality. Unless you reconcile them, it will not work. Because remember, in healthcare, market failures are most predominant. Because as a patient, if I'm smart, if I'm knowledgeable, I know how to utilize the benefits to the maximum extent as long as I don't have to pay.
Yes.
The poorer citizen, uninformed citizen, uses it much less. And in healthcare, once private sector is involved, it's necessary to involve it. But once private sector is involved, there's always a temptation to bill more, do more, get more money, get more business. Supplier-induced demand. It is not the condition that demands supply. It is the supplier that induces demand because I get more payment, unnecessary diagnostics, unnecessary interventions, sometimes even fraudulent interventions perhaps. Asymmetry of information. The provider knows a lot more than me. In general, it's true with any patient.
Right.
But particularly in a country like India, with enormous poverty and illiteracy, the patient is at the mercy of the service provider. So there are all kinds of what they call moral hazards. Economists call it moral hazards. So markets always don't work. So while you're required to involve the private sector, you must very finely balance the interests of the customer, the patient, the society at large, and the service provider in a harmonious way so that the costs are reasonable. Singapore spends from the government only about 3.5% of GDP. It used to be 3% after COVID, it became 3.5%. The private sector, all people from their pocket, through insurance payments, through provident fund monies drawn for the healthcare and so on and so forth, they spend probably another 2.5%. 6% of GDP is total spend. It has probably the world's best quality care. Better than 10% spent in Britain, mostly government exchequer. 18% spent in America, half government and half out of pocket. It's absurd. So the design, apart from allocation of resources and understanding healthcare needs of society, they're equally important. And it also means that hospitalization is not the primary means of helping the patients preserve health. Primary care is the primary thing. When the primary care fails, then hospitalization comes. When beyond primary care there is an illness, hospitalization comes. But remember, 80% of illnesses are prevented or diagnosed early and managed quickly and safely and cheaply through primary care, preventive care and primary care. So none of this, Arogyasri model, Ayushman Bharat model, they are necessary, but they are not a substitute to primary care. You require a primary care model so that there is too many cases don't have to become hospitalization cases. Take diabetes. Now, all kinds of non-communicable diseases are now growing. Take diabetes, take high blood pressure, and many other chronic problems. If you monitor regularly, diagnose early, and manage the patient, you will not have complicated problems later, kidney failure and all kinds of things, or blood pressure leading to several complications, etc. But if you don't have that, if you allow the problem to become complicated, then heroic interventions, high cost, with very limited benefit to the patient, but society bears enormous cost or the individual bears enormous cost. So you have to look at the whole thing holistically. Right. Arogyasri and Ayushman Bharat, a particular keyhole kind of a thing, a small facet of healthcare, politically profitable, immediately giving relief to the patients financially, if not improved healthcare, it became a hit. But you must look at the bigger picture and integrate the model, design it in a cost-effective manner, rational manner to maximize the patient welfare at the least possible cost to the exchequer.
Right, sir. Then how do we incentivize policymakers to adopt a model that is universal, accessible and affordable to all, not misused?
There are two incentives. Incentive one is the public finances. Every government in India is strapped for money. Even rich governments like America are strapped for money. There's a question of us. So, any government which has a sense of the future, not Ek Din Ka Sultan. After all, they have a stake in governance, right? Yes. In power or opposition. They have to take charge of the public finances and address the needs of the people. So, unless they look at satisfying the people and improving the health at the reasonable cost, affordable cost and sustainable cost, ultimately they will go into a crisis. That is one incentive. The second is awareness, the kind of discussions that we're having. The deep awareness. Most patients, most public and media, they want to know there's a problem, there's a hospital care. But there's so much more to healthcare.
Yes. So
supposing that knowledge spreads, what is happening in the rest of the world? Why is it that America spends, the richest country on earth, 18% of GDP, 18%. That means on per capita basis, roughly about $13,000 is spent per year on healthcare. Britain spends 10% of GDP. All government. America, half government, half private. Phenomenal sums. And yet, go to America, even doctors are afraid of illness. Almost every patient is worried about illness. And in the richest country in the world, even today after Obamacare and all kinds of interventions, still about 10 million, 15 million, maybe 20 million people have no insurance. The people in good health don't want insurance. They prefer to pay a penalty because if you don't take insurance, you have to pay a penalty under Obamacare. Okay. I don't know if Trump has dismantled it. He's promising to do it. The latest stage, I do not know. Whereas the people who need it because they're potentially sick or really sick, they cannot afford. So it's a very peculiar thing. What happens if sickly people, they seek insurance? The cost per capita goes up because the healthy people are avoiding. Risk pooling works when everybody is in.
Right.
90% don't need it, but they pay a little bit amount. 10% need it, they also pay a little bit amount, but their needs are taken care of. So this is the case where the costs are distributed, benefits are concentrated. So whenever costs are distributed, benefits are concentrated, unless you're very careful about designing the model, it's always problematic implementing it.
Right.
All kinds of distortions kick in. And the insurance company, they want to save money. The hospital or the medical service providers, they want to earn money. The patient, she wants more care and better care without knowing what is actually better care. Net result is all-round dissatisfaction and high costs. So much so, you might have remembered, the United Health Insurance, America's biggest health insurance company, the chief executive was assassinated a few months ago. And when a young man killed him, a significant part of the society celebrated that. They regard him as a hero, lionized him.
Yes.
Because there's so much of anger and angst. That is the worst way to manage a healthcare system. So without getting into that, the blind imitation of American model is not a very wise thing. Therefore, graded healthcare, primary care, secondary care as I would call it, except the heroic interventions, simple interventions, easily treatable and very definitive interventions. Then tertiary care, government funded and government facilities, and then integration of all these models with a lot of checks and balances and monitoring and high quality research and rigorous protocols and health monitoring system, health records keeping system. We have a law, but we must actually operationalize. So there's a lot more complexity in healthcare. But you have the rudiments beginning to take shape in India. And unless we now relook at this Arogyasri PM Ayushman Bharat model, eventually, by the time you realize what happened in 10 years' time, the cost will skyrocket, the benefits will stagnate, the country will wonder, where do I get the money?
Yes.
Right now, we're not there because we're only spending 1% of GDP on healthcare from the government. Remember, America 9% from the government exchequer, Britain 10%, even Singapore 3.5%, India
1%.
just 1%. We are about the lowest among the significant countries, definitely lowest in GDP, G20. So we have to increase it, but we can't increase unreasonably. My own estimate is if another 0.5% to 1% over a period of 3-4 years, we increase it gradually, but design it differently in a cost effective, rational manner, we can give fairly high quality healthcare at the lowest possible cost.
Yes, sir. So we cannot depend entirely on private insurance.
We need private sector, but not depending entirely on private insurance is not very wise. Certainly, those who can afford, who want it, let them go the way. Already it's happening. But private insurance in India today is minuscule. In a country where healthcare expenditure probably is of the order of about 4% GDP, private and government, and that means about 12 lakh crores, 10 lakh crores, 11 lakh crores. The insurance total premiums, which I just check, you can Google the data. I think it's well under 1 lakh crores. Actually, the number I had some years ago was 28,000, 30,000 crores. Maybe it's now become 40, 50,000 crores. It's minuscule. Because remember, 85% of Indian workers are in the unorganized sector, low wages, low skills, mostly semi-literate and poor. Insurance in healthcare, private sector insurance will never work unless you have payroll taxes. In America, for instance, the Medicare tax is collected along with income tax and in a monthly basis along with what they call social security. Medicare tax is collected. That's possible only when there's a regular monthly wage paying employer and employee relationship. In India, only about 11 to 12%, 15% maximum are regular wage earners with a secure wage, with a paycheck. So it's unrealistic that the rest of the 85% will have anything like private insurance. And that's why government has come with single payer, government funded. Insurance is merely named to manage. Basically, it's a government funded healthcare system. You're picking up the bills.
Yes.
So there are limitations, particularly in India. But even in a country like America, you are seeing the limitations of insurance-based health system. It must be much more sophisticated based on the best practices in the world.
So Singapore is a highly formalized economy, and their health system is also funded by taxation and provident fund money. So how will such a system be applied to India, where, as you said, 80% of the economy is informal?
Absolutely. So you can't replicate a Singapore model here, but you learn lessons from Singapore model. You learn lessons from the American experience. You learn lessons from the NHS of Britain. Britain in 1948, when they launched it, it was a remarkable experiment. For the first time in human history, the state said, we will take care of you from birth to death. All your healthcare needs, the Prime Minister and a commoner and an ordinary worker will have the same quality of care without paying out of pocket. That was a daring dream. It worked like a charm for some time. But now it's run into serious difficulties because they didn't anticipate the problems of aging. With aging, what happens? Higher cost of care, lower benefits of care.
Yes.
Fewer people earning, more people spending public money. And the country cannot afford to spend that kind of money. So all this they didn't anticipate. So Lee Kuan Yew in Singapore anticipated all this. In 1960s, when he was initiating, he was of course influenced by Britain, former British colony and all that. But they thought through it very carefully. They decided to design a model which actually is sustainable, which alters the incentives, and which brings down the cost, and yet ensure quality. And they succeeded remarkably. So the principles embedded in that, to the extent they're applicable, taking advantage of our strengths. For instance, we have great strengths.
Yeah.
Our cost of pharmaceuticals is the lowest in the world, with good quality. Our cost of even high-end interventions like heart surgery is the lowest in the world, with good quality. So we have advantages if we know how to leverage them. We have no dearth of personnel. We have 120,000 doctors produced every year in the country. And the registers, there are probably 16 or 17 lakh doctors in India registered. Probably a quarter of them are actually not productively employed because we haven't designed a healthcare system that reaches everybody. And everybody can't afford to employ a doctor in private sector. So they're not adequately utilized. The resources are not adequately utilized. We have a first-rate cold chain and your immunization system. For a poor country, we are remarkable in immunization. So, though limited immunizations we take up, we do it very well. So there are some things which are very strong in India. So we leverage our strengths. We understand the best practices. We design a model where the incentives are altered to get the best outcomes.
Thank you for your time, sir.